Hello, this is Mirrakhimov speaking. I'm one of the cardiac anesthesiologists at the University of Kentucky, where I also serve as the director of point-of-care ultrasound within the Department of Anesthesiology. Today we'll be talking about an introduction to advanced cardiac point-of-care ultrasound, part 1. This is a topic of interest for some of our residents who want to advance their knowledge and skills in cardiac point-of-care ultrasound, and also, I believe, more of use for our critical care anesthesia fellows and cardiac anesthesiology fellows. Let's get started. I have no conflict of interest to report for this presentation. Our agenda for today's presentation includes coronary blood supply, echocardiographic assessment of the LV systolic function and RV systolic function, to understand the Doppler effect and learn how different Doppler modalities work, and to study the importance of ventricular diastole and its echocardiographic assessment. So let's review the basics of coronary blood supply. Here on the left part of the screen, you see a depiction of coronary artery anatomy. Here you see the proximal aorta, aortic root, and sinuses of Valsalva. Left main coronary artery originates from the left sinus of Valsalva, and the right coronary artery stems from the right sinus of Valsalva. In the vast majority of patients, left main further subdivides into LAD, or left anterior descending, and left circumflex. In a sizable minority of patients, there is another branch coming off of left main, which is ramus intermedius. Then we see the right coronary artery, which gives branches to AV node, sinus node, to the conal branch, and acute marginal branches as well. LAD gives septal branches and diagonal branches. Left circumflex gives a branch towards left atrium as well as obtuse marginal. Sometimes you can see a question on the test about whether the patient has right dominant, left dominant, or codominant coronary circulation. What it comes to, from which artery is posterior descending artery coming from? In the right dominant circulation, posterior descending artery originates from the right coronary artery. In the left dominant circulation, the posterior descending artery comes off of the circumflex. And in the codominant coronary circulation, it comes off from both circumflex and the right coronary artery. And here, in this particular image, you see that the PDA, or posterior descending artery, comes off of the right coronary artery, telling that this patient has a right dominant circulation. It is important to note that the majority of patients have a right dominant coronary circulation. Here on the right part of the screen, you see a representation of a coronary blood supply in relation to the ventricular walls. You have 4-chamber view on the left, 2-chamber view in the middle, and long axis or 3-chamber view on the right. You have a mid-papillary view on the bottom left. You see that the free wall of the right ventricle in the 4-chamber view is supplied by the RCA. The base of the interventricular septum is supplied by the RCA. Mid-papillary level of the interventricular septum here in the 4-chamber view is either supplied by the RCA or LAD. And the apical part of interventricular septum is supplied by the LAD. Again, in the 4-chamber view, you have septal walls and lateral walls. In the 2-chamber view, you have anterior wall and inferior wall. This image is from the TEE, and you see that there's a left atrial appendage on the top right of the 2-chamber view. So this is anterior wall, which is supplied by LAD territory. Opposite to it is inferior wall, and again you see that the basal and mid-papillary level are supplied by the RCA. An apical part of the inferior wall is supplied by the LAD. Next, we look at the long axis view. We see that anteroseptal wall is supplied by the LAD, and inferior lateral wall is either supplied by the RCA or circumflex. And in the mid-papillary level, you see that the RV and this level is supplied by the RCA. Inferior wall is typically supplied by the RCA as well, Then you see that anterior wall and anterior septal wall are supplied by the LAD. Inferior septal wall is either supplied by the LAD or RCA, and the lateral walls, depending whether it is inferior lateral wall, is supplied by either RCA or circumflex, and the anterior lateral wall is either supplied by the LAD or circumflex. Again, just to remind, this image is from the TE, and again, for the mid-papillary view on TE, the top wall is going to be inferior wall, and the bottom wall will be anterior wall, which is reversed for TTE. Again, for TTE, if it's a TTE image, on the top you will see anterior wall, on the bottom you will see inferior wall. Please pause the video if you need more time to review this concept. There are multiple tools which are available in modern echocardiography on how to assess left ventricular systolic function. Obviously, some of them are quite advanced and unfortunately not a part of a point-of-care ultrasound machine armamentarium. Some of the available modalities which you can use to assess LV systolic function include E-point septal separation or EPSS, fractional shortening or FS, fractional area change or FAC, and ejection fraction. So let's talk about EPSS or E-point septal separation. In order to assess for this, first you want to obtain a peristernal long axis view. Then you use M mode and cut through the interventricular septum and anterior leaflet of the mitral valve. Here is a frozen image showing you EPSS. So E point directs towards the E wave, which is early diastolic filling, and it's marked for you here. What you need to do is to measure the distance from the interventricular septum to the E point. A normal value is less than 7 millimeters. Value more than 10 millimeters is strongly suggestive of reduced ejection fraction. However, there are some limitations. Patients who have mitral valve pathology, such as mitral stenosis because of restricted mitral leaflet mobility, mitral regurgitation, mitral annular calcification, aortic regurgitation, left ventricular hypertrophy, and regional wall motion pathology, this EPSS modality is potentially less useful. Again, at this particular view, you're only assessing the basal wall motion. And again, you're not assessing the mid-pap or apical. Again, if you have regional wall motion pathology, you can potentially underestimate or overestimate the systolic function. Nevertheless, it is a quite useful and quick bedside tool to utilize in appropriate patients. Please pause the video if you need more time to review this concept. Next, let's discuss fractional shortening of the left ventricle, or FS for short. First, obtain a classical peristernal short axis view at the mid-papillary level. Utilize motion mode, or M mode, and cut through the anterior and inferior walls. Measure dimensions, such as LV and diastolic diameter, and LV and systolic diameter. Ideally, you need to have EKGs to better understand when systole ends and diastole starts. If you don't have EKGs, and diastole typically corresponds to the biggest LV cavity, and then systole corresponds to the smallest LV cavity. The formula for FS is LV and diastolic diameter minus LV and systolic diameter divided by LV and diastolic diameter times 100. Normal value for fractional shortening is 28 to 42%. There are some important limitations, however, such as regional wall motion abnormalities. Since you're only cutting through the mid portion of the left ventricle, it is a load-dependent assessment tool. For example, patients who have increased preload can make fractional shortening look better than it is, and patients who have reduced afterload, such as patients on vasodilators and patients with septic shock, can also make fractional shortening appear better than the actual contractility. And obviously, high afterload or hypertensive crisis can make fractional shortening appear worse than it actually is. In addition to that, left ventricular hypertrophy can overestimate systolic contractility if assessed by the fractional shortening. Please pause the video if you need more time to review this important concept. Next is fractional area change, or FAC. In order to get this, you first obtain cranial short axis, again at the mid-papillary level, or you could also obtain apical four-chamber view. What you'll need to do is trace the endocardial border at end systole and then diastole, excluding papillary muscles as shown here on the top left image. Again, it is ideal to have a EKG to better understand the timing of cardiac events. The formula is very similar to fractional shortening, except for diameter, we have area here. So normal parameters for LV fractional area change are 35 to 40%. Limitations are important to remember, which include off-axis imaging. Again, it's only one cross-sectional area change, and regional wall motion abnormality can also affect the credibility of your results, as for fractional shortening. However, it is believed to be a superior and more accurate study of LV systolic function compared to fractional shortening. Please pause the video if you need more time to review this important concept. And finally, let's talk about left ventricular ejection fraction. In order to obtain this measurement, you need to obtain apical four-chamber and apical two-chamber views. In each view, you'll need to trace the endocardial border during both end systole and end diastole. Again, having EKG tracing is important. The formula again is very similar, but instead of area, as for fractional area of change, use volume here. So end diastolic volume minus end systolic volume divided by end diastolic volume times 100. There are certain limitations. Obviously, good windows are essential. It is also a load-dependent parameter similar to fractional shortening and fractional area of change. Again, not every point of care ultrasound machine has the software in order to help you calculate the EF. And here you have different values that you consider to be normal up to severely reduced ejection fraction of the left ventricle. Please pause the video if you need more time to review this important concept. Next, we talk and discuss echocardiographic assessment of the right ventricle. Before we get to the echocardiography of the right ventricle, it is important for us to understand the anatomy and blood supply, followed by RV physiology. So let's review some basic facts related to right ventricular anatomy. It is the most anteriorly positioned chamber. It has several walls, such as anterior wall, inferior wall, and septal wall. Septal wall is also known as medial wall. Right ventricle consists of several important regions, such as inlet or inflow, consisting of tricuspid valve, posterior inferior trabeculated segments, and outlet or infundibulum, consisting of anterior superior segments, which is usually free of trabeculations, and also including right ventricular outflow tract and pulmonic valve. Please pause this video if you need more time to review this important slide. It is very important for us to understand right ventricular coronal blood supply, which is typically supplied by several branches of the right coronary artery, such as acute marginal branch, conus branch, and PDA when it's stemmed from the RCA, like in the majority of population. Also, it is important to remember that LAD contributes important blood supply to the right ventricle as well. For example, apex of the right ventricle and large portion of the interventricular septum are supplied by the LAD. Please pause this video if you need more time to review this important concept. There is another important fact which you need to know about the right ventricle, at least under normal physiological conditions. We know that left ventricle coronary perfusion occurs predominantly during diastole. Under normal condition, the right ventricle is perfused during both cardiac cycles, meaning during both systole and diastole. Let's discuss the basic facts of normal right ventricular physiology. Under normal conditions, right ventricle ejects into low pressure circulation within pulmonary artery and its branches. Because of that, the right ventricle has much lower muscle mass than left ventricle, and because of that, it doesn't do well against acute arises in pulmonary vascular resistance. Its shape and anatomy is quite complex, which complicates its echocardiographic assessment. It is described to be as crescent. It has peristaltic contraction, has several patterns of muscle fiber shortening, such as longitudinal shortening, typically from the free wall of the RV towards apex, and transverse or inward shortening. Left ventricle contributes significantly to RV ejection via septal contribution. Please pause this video if you need more time to read this important concept. So obviously, like I said, RV is very difficult to fully assess with echocardiography because of its shape and location. However, you still can get a lot by just looking at the RV and comparing its function and size to the left ventricle. On the top right, you have apical four-chamber view, where you see that the RV is bigger in size than the left ventricle. Its contractility is decreased, and you have heavily trabeculated tissue near the RV apex. On the bottom right, you see a parasternal short axis view with significantly enlarged right ventricle and leftward deviation of the intraventricular septum, so-called D-sign septum, suggestive of right ventricular pressure and volume overload. Just to summarize, normal RV should be less than 2/3 of the LV, typically assessed in the apical four-chamber view. Mild RV dilation is described when RV is bigger than 2/3 of the LV, but smaller than LV. Moderate RV dilation is typically described when the right ventricle is about the same size as the left ventricle, and severe RV dilation is described when the RV is larger than the LV and the apex of the heart is formed by the right ventricle. Again, you also want to assess the size and function of the left ventricle, see if it is underfilled to get an idea about the LV cardiac output. You also want to assess the presence and degree of tricuspid regurgitation. Please pause the video if you need more time to review this important concept. There are different echocardiographic tools which we can use in order to assess longitudinal RV shortening. One is tricuspid annular plane systolic excursion, or TAPSE. We'll need to utilize M mode for that. Again, you obtain RV-focused four-chamber view, and on the bottom right, you see measurement of TAPSE. Next one is when you utilize tissue Doppler, and this one is called peak systolic velocity of the basal free wall, or S prime. Again, the normal value is 9.5 centimeters per second. For both of those parameters, you place the cursor through the lateral edge of the tricuspid valve annulus. Again, for TAPSE, you use M mode or motion mode, and for S prime, you use tissue Doppler imaging. Please pause the video if you need more time to review this concept. Next is right ventricular fractional area change, or FAC, which provides a more accurate assessment of our systolic function compared to TAPSE or S prime, because here you're not only assessing the longitudinal contractility or fiber motion of the right ventricle, but also you're assessing the inward motion of the right ventricle as well. In order to obtain fractional area change, you first get RV-focused apical four-chamber view, and then similarly to left ventricle, you trace the endocardial border, both at then diastole and then systole. You exclude trabeculation of the right ventricle, and again the formula is the same as for LV, and normal fractional area change for the right ventricle is more than 35%. Please pause this video if you need more time to review this important concept. Next, let's discuss a Doppler effect or Doppler shift. It was named after famous Austrian physicist Christian Doppler. Doppler shift is a change of frequency reflected of a moving object. Imagine an ambulance either approaching or moving away from an observer. There will be a positive Doppler shift when the ambulance is approaching an observer, and there will be a negative Doppler shift when the ambulance is moving away from an observer. There's a Doppler equation which is important for us to have an idea about. It is Fd, which is Doppler, equals to 2f0, which is 2 times transmitted frequency of the ultrasound times velocity of moving blood times cosine theta, which is the angle between the ultrasound beam and the direction of blood flow, divided by c, which is speed of sound in soft tissue, which is most of the time assumed to be 1540 meters per second or 1540 meters per second. Please pause this video if you need more time to understand this important concept. Let's talk about angle of incidence and Doppler accuracy. Velocities will be underestimated if the angle of incidence is more than 0. For example, if your cosine theta is 20 degrees, you'll underestimate the velocities by 6%. And if, for example, your cosine theta is 60 degrees, you'll underestimate velocities by approximately 50%. If your cosine theta is 90 degrees, you will not detect any flow or any velocities, not because they are not there, but because the Doppler alignment is not optimal for you to detect any. So let's take a look. On the top right image, you have a parasternal long axis clip. In this clip, we typically measure LVUT diameter within 1 centimeter of aortic valve. This view will not give you a good Doppler angle, and if you were to use it for LVUT stroke volume estimation, you will severely underestimate the stroke volume and cardiac output because of poor Doppler angles. Compare this to apical 5-chamber view shown on the bottom right, where you have very good Doppler angle alignment and where you will very unlikely to significantly underestimate velocities either through the LVOT or aortic valve. Again, please pause the video if you need more time to review and understand this important concept. So first, let's talk about the pulse wave Doppler, or PWD. In this modality, the ultrasound machine sends out a beam in short pulses and listens for the returning sound. The advantage includes an ability to precisely locate the origin of the Doppler shift. The disadvantage is aliasing, or inability to accurately measure the velocity and its direction. On the bottom right video clip, you see a flying helicopter, and unfortunately, we cannot really tell the direction of the main rotor blade movement because of the same concept of aliasing. Please pause the video if you need more time to review this important concept. So let's keep talking about the pulse wave Doppler. On the top right of the screen, you see a typical spectral waveform of the pulse wave Doppler. Again, you use a specific gate at which you want to measure the velocity change, typically placed at the area of interest. It is also known as a sampling gate. Please pause the video if you need more time to review this slide. So how can we decrease the aliasing phenomenon in pulse wave Doppler? First, one can use a lower frequency transducer. It is important to remember that the Nyquist limit, which is a maximal Doppler shift which we can measure before aliasing occurs, equals to pulse repetition frequency of the ultrasound machine divided by 2. What we can do is increase pulse repetition frequency by reducing the depths of our area of interest and narrow the sector widths and color box to improve the pulse repetition frequency. Again, we can lower the transducer frequency, we can reduce the depths, and narrow the sector widths and color box to improve our pulse repetition frequency. Please pause this video if you need more time to review this concept. Next, we talk about tissue Doppler. which is a variant of a pulse wave Doppler with a low pass wall filter on. What it means is that it filters out low velocity signals but high amplitude signals, typically coming off the myocardium rather than blood. And on the left part of the screen, you see a tissue Doppler assessment of a lateral mitral valve annulus, where you have E prime, A prime, and S prime velocities. Tissue Doppler can be used in assessing diastolic function and systolic function of both ventricles. Please pause this video if you need more time to review this concept. Another form of pulse wave Doppler is color flow Doppler, as shown here in the parasternal long axis view. Here the patient has aortic insufficiency and mitral insufficiency. It is important to remember that the colors have nothing to do whether the flow is arterial or venous, but rather follow a mnemonic called BART, which means blue away and red towards the probe. Please pause this video if you need more time to review this concept. Another variant of a pulse wave Doppler is a power Doppler. It signifies the presence of a Doppler shift, but doesn't tell you about the direction or speed. Here on the right part of the screen, you see a comparison of color flow Doppler on the left and power Doppler on the right. Again, in power Doppler, you just know that there's a Doppler shift, but you don't know the velocity, and no direction information will be available to you. Let's follow this discussion by talking about continuous wave Doppler, or CW Doppler. In this particular modality, you have two Upson crystals. One is constantly sending, and the other one is constantly listening or receiving signals. The advantage of this modality is in its ability to measure high velocities. And the disadvantage is range ambiguity, which means that you can't 100% be sure where this velocity is coming from along the pass. On the left part of the screen, you see a comparison of spectral Doppler display for pulse wave Doppler on the left and continuous wave Doppler on the right. Just again, to emphasize, with pulse wave Doppler, you're measuring a precise area of interest by placing a gate. With continuous wave Doppler, you're assessing the whole plane of your area of interest, so you cannot be 100% sure where the highest velocity is coming from. Please pause this video if you need it to review this important concept. And finally, we have a hybrid between continuous wave Doppler and pulse wave Doppler, which is called high pulse repetition frequency Doppler. Again, most of the times what it does is it sends another signal before it receives the previous one. It has the ability to accurately measure higher velocities compared to pulse wave Doppler, but again, it has the problem of range ambiguity similarly to continuous wave Doppler. Please pause this video if you need more time to review this concept. So finally, let's summarize the role of Doppler in cardiac ultrasound. We can use it to estimate flow gradients, such as through valves and anatomic obstructions. For this, we typically use continuous wave Doppler because of its ability to measure high velocities. We can also utilize Doppler to help us estimate stroke volume and cardiac output, because here we need to be precise where we are measuring the flows. We typically utilize pulse wave Doppler. Pulse wave Doppler is also used in estimation of shunt fraction. Tissue Doppler is typically used in assessing the systolic and diastolic function. And again, Doppler is also used in assessing the direction of blood flow in stenotic lesions and regurgitant lesions as well, such as, for example, mitral insufficiency, aortic insufficiency, and aortic stenosis, among many others. Please pause this video if you need more time to understand this important concept. Finally, let's discuss left ventricular diastole, which is often a confusing and overlooked topic. Diastole is an active process, which means it requires energy. It is typically subdivided into 4 parts, such as isovolumetric relaxation, which occurs immediately after aortic valve closure, where ventricular pressure falls rapidly. And again, you need energy for that. Next part of diastole is early rapid filling, when your mitral and intercostal valve are opened and the blood flows from the left atrium into the LV because of the pressure gradient between the left atrium and left ventricle. In normal patients, approximately 70 to 80% of LV filling occurs during early rapid filling phase. Next phase is diastasis, where you have equalization between left atrial and left ventricular pressures, and typically minimal to no LV filling. Finally, you have an atrial contraction phase, which typically contributes to approximately 20 to 30% of left ventricular filling under normal circumstances. Again, you need to have a synchronized atrial contraction, typically sinus beat, in order to have an atrial contraction phase. On this slide here on the left, you see a diagram showing different phases of diastole corresponding to different EKG parameters and LV filling. Please pause this video if you need more time to review this important concept. So the question comes down to this: how much does it matter if the patient has diastolic dysfunction? Surprisingly, patients who have diastolic dysfunction do worse than patients who have systolic dysfunction in non-cardiac patients. They typically have longer hospitalization. These patients are extremely sensitive to volume status, heart rate, and rhythm disturbances. They're at high risk for pulmonary edema and myocardial ischemia. Very recently, American Society of Echocardiography released its updated version of LV diastole guidelines. And here's a statement from these guidelines, saying that these guidelines should not be applied to children, normal pregnant women, or the intraoperative setting. Probably we should not be applying these guidelines to our intraoperative patients who we follow with TEE, but we can still utilize these guidelines when we are assessing the patients in the preoperative period of their care. I refer you to this wonderful document if you want to get more detailed or in-depth information about the LV diastole guidelines. So what are the common etiologies of diastolic dysfunction in the left ventricle? Hypertension, coronary artery disease, aortic stenosis, hypertrophic obstructive cardiomyopathy or HOCM, restrictive cardiomyopathy such as amyloid, sarcoid, and hemochromatosis, among many others. For example, here on the left, you see an apical 4-chamber view. In this particular image, the patient has significant diffuse left ventricular hypertrophy and very likely have some degree of diastolic dysfunction. So what are the echocardiographic parameters which we can utilize in assessment of LV diastolic function, which include transmitral inflow velocities, tissue Doppler of the lateral and septal mitral valve, isovolemic relaxation time or IVRT, left atrial volume, peak TR velocity, and pulmonary venous flow profile. Obviously, it is oversimplified list, and I refer you to ASE or American Society of Echocardiography diastolic guidelines for more in-depth assessment. Obviously, there are some tools which are beyond the scope of this talk, such as, for example, color and mode propagation and left atrial strain. So first, let's talk about the transmitral inflow. First, you want to obtain apical 4-chamber view. Utilize pulse wave Doppler and place the sampling gate at the level of the mitral valve leaflet tips. It is important to have EKG in order to better understand the timing of events. Here on the right part of the screen, you see a frozen image demonstrating the transmitral inflow velocities. You have E wave and A wave. A wave typically follows the P wave on EKG, and E wave typically follows the T wave on the 12-lead EKG or EKG tracing. You also have a deceleration time. In addition to measuring peak velocities of the E and A wave, you need to measure the ratio of the E and A wave and the E wave deceleration time. In this particular image, deceleration time is labeled as DT. Please pause this video if you need more time to review this important slide. So next, let's discuss different patterns of transmitral inflow. On the top part of this graph, you have a normal pattern where E wave is slower than A wave. Then you have three types of diastolic dysfunction. First being impaired relaxation. In impaired relaxation, you see that the E wave velocity is much smaller than the A wave velocity. This occurs because the LV relaxation is compromised. However, the left atrium pressure is still normal. That is why you need to have a higher contribution of the A wave or atrial contraction or atrial kick in order to fill the left ventricle. Impaired relaxation is typically followed by a pseudonormal pattern where you have left atrial pressure increase. That is why, because of the gradient between the left atrial pressure and LV, you have predominantly E filling during the early stage of diastole, which is typically followed by restrictive type of diastolic dysfunction, where you have E to A ratio at least 2:1 or higher. Different clinical scenarios and maneuvers can change this relationship. For example, reduced preload and Valsalva maneuver can unmask pseudonormal pattern and make it impaired relaxation. That is how sometimes one can differentiate between the two. Because if you do Valsalva maneuver or reduce preload for a normal pattern, you'll have a symmetric decline in both E and A wave velocity. Restrictive pattern may or may not become pseudonormal with Valsalva or reduced preload. When it doesn't return to pseudonormal from restrictive pattern, it is considered to be a bad sign and reflective of unstaged diastolic dysfunction. Aging by itself is associated with impaired relaxation pattern. Please pause this video if you need more time to understand this concept. Next, we talk about the tissue Doppler in its role in diastolic assessment. First, you want to obtain an apical four-chamber view. Utilize tissue Doppler imaging, and you can place a sampling gate at both lateral mitral valve annulus first, and then at the septal mitral valve annulus first. And here you measure the E prime velocity, which is similar to E velocity on a pulse wave Doppler. Again, for both pulse wave Doppler and tissue Doppler, it's important for us to remember that Doppler is angle dependent. So you need to optimize your angles in order to obtain true velocities. And tissue Doppler can sometimes be used to help understand whether the patient has normal or pseudonormal diastolic dysfunction. Please pause this video if you need more time to review this important concept. Next, we discuss about the avasolemic relaxation time, or IVRT, as a measurement of diastolic dysfunction. In order to obtain these measurements, you first get apical 5-chamber view or apical 3-chamber view. You utilize continuous wave Doppler through the aortic valve. And here on the right part of the screen, you see a typical spectral Doppler profile. IVRT happens in the time interval between the aortic valve closure or immediately after ejection and mitral valve opening or just immediately before E wave. This measurement, or IVRT measurement, is directly related to LV relaxation and inversely related to left atrial pressure. Please pause this video if you need more time to review this concept. Next, we discuss about index left atrial volume, or index to body surface area. In order to obtain that, you get apical 4-chamber and apical 2-chamber view. You trace the left atrium during end systole, which is typically 1 to 2 frames before mitral valve is opened. And then you divide the left atrial area by body surface area. And again, when you do trace the left atrium, it is important to exclude left atrial appendage and pulmonary vein from the measurement. Again, not every point-of-care ultrasound will have the software to measure the left atrial volume. Another thing to remember that left atrium volume can be increased not only in patients who have diastolic dysfunction, but also in patients who have mitral valve pathology, such as significant mitral regurgitation or mitral stenosis, which is something to keep in mind. Diastolic guidelines recommend measurement of the peak tricuspid regurgitation velocity. In order to obtain this measurement, you want to get apical four-chamber view focused on the tricuspid valve. You utilize color flow Doppler to establish the tricuspid regurgitation and its direction, followed by continuous wave Doppler through the center of the tricuspid regurgitation jet, followed by measuring the peak velocity of the tricuspid regurgitation, which is demonstrated on the frozen image on the left part of the screen. Please pause this video if you need more time to review this important concept. Finally, we discussed the pulmonary venous flow profile and its role in assessing the left ventricular diastolic function. Pulmonary veins are sometimes quite difficult to visualize with transthoracic echo, and right upper pulmonary vein is typically the easiest one to image. In order to image the right upper pulmonary vein, you first obtain classical apical four-chamber view, followed by optimization of the left atrial image. You will probably need to tilt the probe more towards the feet or caudate, and may need to rotate the probe slightly counterclockwise. The right upper pulmonary vein will be coming more the vertical position into the left atrium as shown on the image on the bottom right. Then you use the color flow Doppler to help identify the blood flow in the right upper pulmonary vein, followed by placement of a pulse wave Doppler sampling gate approximately 1 to 2 centimeters within the right upper pulmonary vein. And on the top right part of the screen, you see a typical spectral Doppler profile of a pulmonary vein, which are a reverse wave or atrial reverse wave, systolic wave or S wave, and diastolic wave or D wave. Let's review the pulmonary venous Doppler profile and respective waves. We have atrial reverse wave or AR wave, typically occurs after the P wave on an EKG tracing. We have two systolic waves, which occur during the systole, such as S1 wave and S2 wave. Some patients will not have two separate S wave, but rather have one. You also have D wave, which occurs during diastole. Please pause this video if you need more time to review this important concept. Let's summarize the assessment of LV diastolic function. First, let's go through this stepwise approach. First, utilize tissue Doppler and measure either septal or lateral E' velocities. Abnormal E' velocities for septal mitral valve is equal or less than 6 centimeters per second, and for lateral mitral valve is equal or less than 7 centimeters per second. This is followed by assessment of left atrium and LV remodeling and elevated left atrial pressure. Parameters which are suggestive of elevated left atrial pressure include average E to E' of more than 14, index left atrial volume of more than 34 milliliters per meter squared, LARS, which is not available for most point-of-care machines, is left atrial strain, is a novel method and beyond the scope of this lecture. You also assess the E to A ratio. If it is less than 0.8, it is reflective of impaired relaxation, and if it is more than or equal to, it is suggestive of restrictive diastolic dysfunction. On the left part of the screen, you see a more detailed chart. And again, here it emphasizes the need to measure E' velocity with tissue Doppler It also shows you the abnormal values for each. You also need to measure the ratio of E velocity, which is obtained with pulse wave Doppler through the mitral inflow, to E prime velocity, which is measured with tissue Doppler. And also the assessment of the tricuspid regurgitation velocity, an abnormal being more than 2.8 meters per second. It gives you important caveats for diastolic dysfunction guidelines. It should not be used in patients who have significant mitral valve disease, such as mitral annular calcification or MAC, mitral regurgitation, mitral stenosis, atrial fibrillation, left ventricular assist device, non-cardiac pulmonary hypertension, pericardial constriction, and heart transplant or HTX here. Also, following these parameters, it gives you an idea whether the patient has a normal left atrial pressure or increased left atrial pressure. And in cases of increased left atrial pressure, depending on the ratio of E to A, if it's more than 2, you will have a grade 3 or restrictive diastolic dysfunction, or grade 2 or pseudonormal diastolic dysfunction. Please pause this video if you need more time to review this important slide. So what about intraoperative TE diastolic assessment? Unfortunately, TE compared to TTE has a very limited ability to measure left atrial volume accurately. On average, we tend to underestimate the left atrial volume with TE by approximately 9%. We also have dynamic loaded shifts, such as bleeding, surgical position, surgical pressure on the heart and major vessels, and positive pressure ventilation, which may complicate the diastolic assessment. Obviously, our anesthesia medications affect contractility, heart rate, preload and afterload. On the left part of the screen, you see a diagram taken from the study published in patients undergoing CABG. This algorithm suggests that measuring tissue Doppler E prime velocity of the mitral valve is an important first step. If it is at least 10 centimeters per second or higher, then your patient has normal diastolic function. If it is less than 10 centimeters per second, then you need more data such as E to A ratio, E to E prime ratio, and deceleration time, and many others. And based on these different parameters, you can classify your patients into grade 1 or impaired relaxation, grade 2 or pseudonormal, and grade 3 or restrictive. Please pause this video if you need more time to review this concept. So in summary, cardiac point-of-care ultrasound is an important tool in the assessment of ventricular systolic performance, which is true for both left and right ventricles. It is essential for us to have an understanding of Doppler effect and appreciate its role and limitations in ultrasound. Diastolic dysfunction, when present, appears to be more predictive of adverse perioperative outcomes compared to systolic dysfunction. Adverse perioperative outcomes are defined as hypotension, cardiac ischemia, and pulmonary edema. Finally, I want to thank you for your attention. If you have any questions, please do not hesitate to contact me on this email address provided on the slide. I wish you all the best and good luck.